Hello and welcome to SNS Podcast. I'm your host, Vijesh Vijayan, and I'm here today with an incredible business leader in healthcare, Miriam Paramore. Miriam is the founder and CEO of RxUtility, and she's one of the top voices on affordability and transparency in healthcare. Miriam, welcome and thank you for joining us.
Thank you so much. It's really great to be here. I appreciate it.
Well, so to set the stage of our conversation, let's hear from you. What was your journey?
Sure. Thank you. I'm happy to. And I'm going to try to keep it short, but it's kind of a long journey because I've been in healthcare and in healthcare tech for 42 years. So when I started in the industry, we were called programmers, and they're still programmers, but I wrote software for HCA, Hospital Corporation of America, and I wrote in COBOL, which there's still a lot of COBOL out there, but we certainly didn't have AI. In fact, I can remember the day in 1984 when the first personal computer was brought into our office. And you may not remember this, but it was pretty big and it had dual floppy disk. It had no permanent memory. So those are the days that I go back to. So I remember, all of that mainframe. Everything was in a mainframe somewhere. Then we had the mini computing revolution. Remember when the smaller computers that weren't that big, and then the personal computer, and of course network computing, and then the internet, and then what we have today. Probably the next biggest thing since the internet would be AI. And so as a techie, I have participated in all of those trends and learned. And now I'm leading an AI native tech company that's focused on prescription affordability. In between there, I led efforts around the standardization of data for the revenue cycle of healthcare, which is, filing claims and making payments. The only policy claim I have to fame from the national policy perspective is when the Affordable Care Act was written, the Obamacare. There was an administrative simplification portion, and it focused on what we were trying to automate with claims and eligibility. Claims were pretty much done, but there were still a lot of paper checks being sent from health plans to doctors. And so I did my first and only lobbying campaign to Washington, where I showed that simple printing and mailing of paper checks was an $11 billion a year cost. And so if you just paid by EFT, then that's what they call a pay for when you put it into a law, because the savings are so immediate. And of course, it was apolitical because, you don't have sort of Republican and Democrat like envelopes. They're just envelopes. So people are like, okay, we could get behind this. And as a result, there's one small paragraph in the ACA that talks about payers being required to pay providers by EFT, and providers being required to accept that. And that was a big win, because anytime we can get rid of paper, we're killing less trees, but we're also becoming more efficient. So that's kind of one little story of my career that's important. But then other things I've done have been just building and running large health IT, health tech companies that serve the market across the sectors. So there's a company called Change Healthcare now that's part of Optum, but it used to be called MDON before it became called Change. I was with that executive company, and we built the company to $1.2 billion and took it public in 2009, which was the largest health IT IPO that had ever happened at that time. The company was subsequently taken back private. We took it back private with Blackstone. And that was when I left that. Myself and most of the executive team kind of left that role. And that was in, 2013-ish, something like that. And the next, 12, 13 years, I've just done a lot of different things. And one of those things is become an investor, an LP at the venture level. I still do a decent amount of angel investing in the health tech space. And I do advising work for private equity. Goldman Sachs, in particular, is what's called an operating advisor. And I'm still an entrepreneur. So I started RxUtility 2 years ago with the simple message of saving people money on medicine.
I'd say I'm impressed, and I'm pretty sure all our listeners are impressed by the trajectory that you have had, and very cool, I would say, in the kind of roles and things you've already accomplished and you're currently in. I want to know a little bit more about RxUtility, but
Sure.
to start off, before we go into the nitty gritty of things, I want to just zoom out and talk about affordability, or that's the space you're currently in prescription
Yes.
affordability. This statement that I saw recently in one of your, one of the fireside chats that you were part of, 6 prices for the same drug.
Yes.
Why?
Yeah. Well, it's a good question. We know how we got here. We are here, and I think the example might have been Skyrizi that I recently gave. So, if I said to you, how much does Skyrizi cost, or how much does Eliquis cost? There's literally no way for you to answer that question. There's no way for any person to answer that question for themselves, and there's a fundamental reason for that, and that is because the payer, there are a couple of reasons. The payers are required to publish their negotiated prices on drugs under the transparency and coverage rule, but they have not yet. They've stalled. So while transparency has moved forward with hospital prices and payer negotiated prices for hospital services, it has not moved forward for medication. So that's one reason why it's so hard for people to know their insured price. But historically, and even today, the way our health system works, a consumer does not know what a prescription costs until they get to the pharmacy counter. And rather than sharing that information, it's hidden, and it's intentionally hidden by their health plan, but specifically in there by their PBM, because they don't want the consumer to know the price, and they don't want consumers to have informed choice around price. So as a result, but they still want to sell, people want to sell drugs, and pharmacies want to fulfill scripts. So so many things have evolved. That's kind of a background I'm giving you that's a block to why transparency around drug cost exists today compared to other types of transparencies. But there are a few ways you can buy drugs, and the way you can buy drugs, it's always so funny when I say that, buy drugs, but buy prescription drugs is what we're talking about. You can use your insurance, okay? And so when a consumer has insurance, they also have a pharmacy benefit. They have a medical benefit and a pharmacy benefit. Oftentimes, those are administered by the same insurance plan or TPA, but sometimes they're different. So you have an insured price when you show up at the pharmacy. If you show up at the pharmacy and you are in your high deductible period, you have to pay the list price of a drug, not the net price. You as a consumer have to pay the list price of a drug. So the price under your high deductible, you're still using insurance, but the price under your high deductible is a different price. And we can talk more about that. It's important. You could not use your insurance and pay cash. You could, so there's 4. So you can use your insurance with a pharmaceutical manufacturer copay coupon alongside your insurance, which is another way. You can choose to pay. So when you choose to pay cash, that's not just, I'm just going to pay cash. There are literally millions and millions of cash price points through dynamic pricing algorithms and data that's dynamic throughout the day that consumers could take advantage of if they could see them all. Consumers know of GoodRx, but GoodRx is not the best cash price. It's just a cash price. So there are a bunch of others. And then the last one would be, well, there's a couple more. There's a government website that has RX in the title of it, so you might buy there. But that's probably mostly intended for cash paying. But then, okay, now last year, for the first time ever, pharmaceutical manufacturers started selling directly to consumers through their pharmaceutical website. So that's called direct to patient or direct to consumer. So all of those things that we just went through has a different price. So it's a different pathway and it's a different price. And that's why we end up with 6 prices for the same drug.
And that's where RxUtility is coming in, right?
Yes, yes.
Okay.
So our goal is to save people money on medicine. And to save people money on medicine, the first thing they have to know is, how much does this thing cost? And so if there's no way to know how much it costs, you have no levers or tool, you can't even get started. All right. So I like to say that we're democratizing drug prices. It's a little bit like having a kayak for drug prices, or, an Expedia for drug prices. So we want to democratize all of these price points. We call it a utility, RxUtility, because we want it to be ubiquitous across the healthcare ecosystem. We want all the companies you work with through innovation. We want any vendors who serve providers, pharmacies, vendors who serve health plans, vendors who serve self-insured employers, the PBMs, the employee benefit brokers, anyone who's looking at benefits navigation companies, patient engagement companies, medication adherence companies. If you're touching a consumer in healthcare, you're touching their their medicine record, because they're going to have medicine. Are they overpaying? Are they paying appropriately? Do they have optionality that they don't know? So the first thing is publish the prices. So we curated the only database of every pharma copay coupon that exists, so that those can be accessible through an API. That represents 1,300 branded drugs. Okay. Then we said, well, what about what's this world of cash? So we just mentioned that GoodRx is one, but Single Care, BuzzRx, Hippo, Blink, I could go on. We have a partnership with Buzz that's in place, and we're putting together partnerships with essentially every cash discount vendor. Those prices are different, and there is a lowest price or a best price among those vendors. So we aggregated all of those cash prices. We aggregated all the prices and have created an API so that you can find the best price. Then we put on top of that a price decisioning layer that helps the consumers to see all these prices side by side. Here's my insurance price. Here's my insurance price if I use a copay coupon. Here's the cash price, the very lowest cash discount card price, and here is the direct to consumer price, you might say. So we have the pharma manufacturer websites, the government websites, fabulous companies like Mark Cuban, which I'm in love with, all of those prices. So when you connect to RxUtility through the API, you can rest assured that you are accessing every price for every drug at every pharmacy. And we believe that that is unique. And we believe that that strict focus on consumer out-of-pocket, it makes us the kind of the go-to resource for consumer price, best price calculator, I kind of call it.
Amazing. Something that you mentioned initially was being AI native, and in RxUtility, I hear that you are using AI. And tell me a bit about where is AI helping in the pricing transparency side of things you're building within RxUtility. Tell me a bit about that.
I will, and I want to share with you and your audience that not only is the RxUtility tech AI native, RxUtility, the company, is AI native. And what do I mean by that? So I'm a serial entrepreneur, and I have used a lot of lawyers. I've used a lot of banks. I've done a lot of things. So I ran the company for a year without a lawyer, just using a robot lawyer, so a kind of a legally trained GPT. And until January, there were only 2 employees in the company. Now we've grown quite a bit and we have 4 employees in the company. And so using AI, I want to encourage everyone to push the AI boundaries as far as you can, just on the corporate infrastructure, the basic things of building a business. We have a fantastic human lawyer now, and we have a fantastic human bookkeeper, but their work is kind of leveled up because the AI underneath it does so much. So it's been such a joy. I can't tell you, it's so exciting to build tech solutions using AI tools today. It's unbelievable. I can't believe, I really can't believe what we can get done from even day to day, week to week, compared to me, writing COBOL code on a green screen, forever ago. It's dramatically different. So we use AI very specifically and intentionally in, I guess, let me call it 3 ways. The first is we write our products using AI tools like most people do. We use it for code development. Okay. Then we use it for QA. Okay. And so in code development and in QA, it's also important to have a human look at it. But even before the human looks at it, you can double check things I like to, do kind of Coke Pepsi with AI agents checking each other. So software development and QA. We use AI native tools for orchestration. And this is where what I think most people do understand, but some may not. If you allow AI to orchestrate itself, you're probably asking for trouble. So to me, the sophisticated smarts around building software with AI is that orchestration layer. It's really important to have a really smart architect-minded engineer doing this orchestration so that you know that you can scale your tech and things aren't going to just sort of fall apart, right? And then the last way we are using AI is through our companion, our AI companion that we haven't yet launched, so I can't say the name, but in 2 weeks, so we will. And I hope I have a chance to come back and tell you a little bit more, maybe 6 months from now. But this AI companion is a conversational generative AI tool. And it's kind of scary when you build these tools because you don't know exactly what they're going to do, right? We have this whole, Skynet, thing out there moving that is this solution I'm building going to really behave the way I hope it will? But we're doing well. So we do plan to launch in beta in about 2 weeks at the NCPDP annual conference, as a matter of fact, which is a great trade organization that your audience may be familiar with. They set the standards for all the data exchange in pharmacy, like the standard of what is in the actual claim itself, the electronic claim. It's a format. And it has to be transmitted a certain way and the content specific and so forth. Format, content, transmission, et cetera. So that foundational, as an aside, that foundational understanding of healthcare data is really essential to any tech company that might want to build something in healthcare. So don't skip over the basics just because you're doing some cool, AI thing. So, but what our digital AI companion is think of her as highly trained on drugs and drug prices. So you can simply say, how much does Eliquis cost? And she'll bring you through your geolocate and bring you through your options and help you decide which price is right for you. And when I say that, it's not always the lowest price. You may want to use your insurance. And sometimes cash is cheaper than insurance. And that's another thing people don't know. Mm. But, once she geolocates your zip, so she knows where you are and can find every price in the zip. She's going to show you the lowest cash price and she's going to show you the average insured price. But if you then say, I just don't want to go to Kroger, I want to go to Publix or whatever, she'll just show you the Publix price. So we are doing this to empower the consumer with informed choice. So that's kind of how we use it. Is that helpful? So inside the building of, and then part of our solution set is a conversational AI companion.
Great. And switching gears over here, I want to talk about the medication affordability benchmark report that
Yes.
you launched last year.
Yes.
Tell us a bit about your findings in that report.
Yes. So we are trying to raise awareness in the industry about the affordability tools that exist for consumers to use, because our focus is strictly the consumer out of pocket, right? And so one of the things that we talk about in the report to drive awareness is our sort of out of control healthcare system here cost more than anywhere else, and the costs keep going like this, but the outcomes keep going like this. So no matter how much money we're spending, we're getting more poor outcomes, and it's costing us more to not get well and not stay healthy. And then the overall percentage of national GDP continues to grow as we creep closer to 20%. So the first thing is to kind of create awareness of what affordability cost us in terms of how it can hurt people. And so we talk about, 98 million people a year abandon scripts at the drugs, at the counter because of cost. We talk about the difference between using cash and using insurance and the delta on price points. We use some examples, for example, like I believe Skyrizi is one of our examples, where that drug is an autoimmune drug. It's an injectable, but you can get it at just a regular pharmacy. You don't have to get it at a specialty pharmacy. But rheumatoid arthritis is one of the key indications for that drug, and it's a very popular drug, but it's very expensive. The consumer out of pocket, their copay is $1,000, $1,000 per month if you want this drug. It's also obviously very expensive for their employer or their plan sponsor. But Skyrizi offers a copay coupon that's funded by the manufacturer. And if you use the Skyrizi copay coupon, you pay $5 instead of $1,000. That is the game. So we're talking about that and amplifying examples, amplifying the number of brands, so 1,300 different drugs across many disease areas. And we kind of bucket them up by disease areas. So you've got, autoimmune drugs, you've got cancer drugs, you've got drugs, dermatological, common things. So you have everything from super expensive kind of niche to just very general. And again, those savings work only on branded drugs, and they bring the consumer price down. So we talk about those things in order to raise awareness and give examples of real savings that matter to people as they're going, from place to place. And then we seek to raise awareness around the access barrier. People kind of use, you hear this, affordability and access, they sort of interchange. We try to stick with the word affordability, like I can't afford it or help me afford this, right? And so we want people to be aware of the abandonment rate. So for example, it's what's the price point when a person walks up to the counter and they just hesitate or it's only $30. $30 is the price point where people hesitate to get this or not. Okay, so people are very price sensitive, especially those who take a lot of medications. So the idea about the benchmark report is just sharing some information. It's about $30 billion of consumer savings a year, which is not nothing. It's a lot. How much of that are consumers taking advantage of? 10%, maybe 15%, if you look at some different reports. All of that money is just laying on the floor. Why are people not using these coupons? Two simple reasons. There's a lack of awareness that they exist, and there's lack of digital distribution. And once again, that's why we take a utility approach, so we can have ubiquitous distribution of these savings opportunities that are out there. And then ways to buy is another thing we talk about as we talk about the increase of the use of cash. So people used to almost never use cash at the pharmacy. Now it's between 11 and 15, again, depending on which study you look at, 11 to 15% of all prescriptions picked up are paid by cash. So that is because lots of times the drugs are not covered under their formulary, and it's just not covered. Sometimes cash is actually cheaper than insurance. And once again, if you can't see any prices, you have no idea, much less price compare. So the purpose of the benchmark report is to hold ourselves accountable at least once a year to publish some trend line sort of data and to give people something they can go back to, kind of like you did, to say, I don't know, what's the macro that's going on here? And we find it to be helpful for ourselves, and we also think for the industry, to just keep that focus on affordability and what's happening around affordability year over year.
You said it's going to be an annual
It
report
is.
that comes out, right? So, how this is going to influence, how this is being received, and the perception of the industry of these findings, and how this is impacting, and how it's helping change the way we look at affordability and prescription, from the point of view of a payer and from the patient. So.
Yes, if I can just respond quickly to that sort of tracking. So, right now the company's very young. We've only been in the market for about a year and a half with our solutions. So we don't have 10 years of experience in data points, but we are collecting data points. So you will begin to see what are the patterns of distribution of these savings, and when are people using cash over insurance. And so we want to be we'll put those things in the benchmark as well, so we can start to see trend lines there in utilization of the drugs and savings to employees and just regular old healthcare consumers, whether they're an employee or not. So that'll become a key part of what we track.
Awesome. So with your partnerships, I hear recently with Scripta and Bus Health.
Yeah.
What is the goal of RxUtility, and where are you trying? What are you trying to accomplish with those partnerships?
So let's start with Buzz, and then we'll talk about Scripta. So Buzz Health, just a great organization. I'm so impressed with the founder story there. There's a lot of philanthropic, B Corp kind of thinking in the ethos of what they're doing with their entity. And they're evolving to have several different solutions across the prescription sort of landscape, of the drug landscape. What they do with us in particular, they have a set of cash discount savings. They're a discount saving card called BuzzRx. And so those price points are negotiated with the pharmacies and the PBMs for cash pricing on basically every medication. But again, they're only one price vendor. So we have an agreement with them to distribute their price points as part of the overall RxUtility solution set. So if they're the lowest price, they will win, but we don't favor them. So we're not picking winners and losers. So I mentioned the other cash card vendors that we're also partnering with. There's a big spread many times across these prices from these different vendors. So we want the consumer to be able to see the best price. But Buzz has been our earliest partner. They're our first partner in this streaming of dynamic, real-time drug prices, which do change throughout the day. They can even be different from, I thought it was, I left my house 3 hours ago. Now I'm at the pharmacy. It could be different. So very complicated, very large data sets that they have at their disposal that they stream with us. We're grateful for the opportunity to distribute their price points into this. And again, we don't change them. We're just distributing. Remember, we're really in the early, let's make some awareness, then people can have choice. Scripta is a different kind of company. Scripta works with plan sponsors. So think of group employers who and health plans. So not either one, who are providing pharmacy benefit to a group of people. And so when you're navigating your pharmacy benefit, Scripta has an app that consumers can use that helps them look up the medication, find basic education, and then tells them what to expect to pay, as we talked earlier about the insured price, et cetera. They didn't necessarily have a robust copay coupon database that they could include. So the first leg of our partnership has been for them to subscribe to our real-time copay coupon catalog and we're looking at the cash stuff too now that we've started with the copay, so that they can simply inject that data into their own workflow. So that's the most common customer relationship and partner relationship that we have is through an API. Now, again, the utility concept, the data, democratize the data, flow it through to the Scripta audience. Scripta will also do, hey, there's a generic, like they'll make the consumer aware there's a generic, or there may be a therapeutic substitution. So they provide perhaps more clinical information than we do, because we're just prices. We're just prices. We are prices, and we're part of their ecosystem now. So their members get more informed choice, more price, and those are two great examples. So we want any and everyone who has pricing that they want to share to stream into us, and then we aggregate, and then everybody can get all the prices from the same location, which is us. And it's very simple. We do make that available through MCP server as well as API. So I'm oversimplifying dramatically, but for those who don't know, we think about it as that behind the scenes, the agent's handshake, sort of a secret agent to agent handshake rather than an API. But of course, you can do it either way through our partnerships.
Amazing. So it's kind of coming in, leading us into the point about interoperability. That it's a buzzword in healthcare right now, and I think it's one of the things that we need to actively try to implement in all our systems, so that we can have a very cohesive way of delivering healthcare. From your standpoint, especially from the space that you're in, what does interoperability mean, and what is urgently needed to be done for interoperability?
Sure. Well, because I've been in this forever, and I mentioned electronic claiming and things like that. In the 80s, claims were filed on a piece of paper, called a HCFA 1500 or a UB92, and people would mail them, and maybe the payer would scan them in on the back end, but it was a lot of paper. It wasn't until the mid-90s that we really got pretty much close to ubiquity in electronic claims filing. But still, the rest of it was manual: phone calls, faxes, eligibility questions between the consumer and the health plan, between the pharmacy and the health plan. What's going on here? Very, very manual. And so people started buying systems, because remember, we got the personal computers, and then we said, mainframes, and we said, mini computers. And then, by the way, there's the cloud now. So people are building out their systems, sectors of the industry, but the pharmacy systems don't talk to the health plan systems. They don't talk to the provider systems. They're all using slightly different data structurally. So in order to interoperate at all, you have to develop standards of information exchange. And those got created with the HIPAA rules. People think of HIPAA as privacy, but it was also had a huge administrative simplification component. That's where those revenue cycle transactions, claims, eligibility request and response, electronic remittance, those things, came to be under the, ANSI X12 kind of structure. Then you had in the pharmacy side, sort of under the HL7 superstructure, the NCPDP is the body that sort of manages those. data structure. So what is the data? What is it called exactly? What is its the nomenclature? How are the fields defined? What order are they in? And what's mandatory and not? All of those nitty gritty, tiny data element details. So you had to have that commonly shared dictionary, right, of what you call things. The lab space is still kind of the wild, wild west because you've got SNOMED and LINK, and there's all these different codings. So you have in codification, if we want to call it that. So procedure codes, diagnostic codes, ICD-10, CPT-4. We were always like 5-10 years behind. It would be like ICD-10, and everybody's using ICD-5. And then everybody, so lots of just structural stuff that made interoperability hard. Okay. When we sort of got 20 years, when we stopped being 20 years behind and got everybody using the HIPAA stuff, the ANSI stuff and the HL7 stuff, by the time we got that done, the technology, that was like the old way to do it. That was like, oh, that was when we lit, lamps by hand with, kerosene and or whatever, I guess lamp oil and so the standards are slow, and then the regulations are slower, or they're equally slow, but the technology is lightning fast, and people are running their own businesses, and they're just like, you guys keep doing I'm going to keep doing this. So it keeps going further and further apart. So then you come into kind of the universe we're in now with FHIR, and so FHIR. Mm-hmm. This is the new way we're going to exchange. We're not going to do batch exchange via ANSI. We're not going to do real-time exchange via pharmacy. In other words, we're not going to do transactional exchange. We will do that. We still do it. It's required. But we need better and different information exchange that is what healthcare would think of as patient-centric or human-centric. Okay. And so those are things like when the EHRs grew up in the world, now you have an electronic health record. And that's really only it's about 20 years, but it's not 40 years, like when I, start. Mm-hmm. So, but they're still getting old. Some of them are very walled gardens, and so we said, okay, well, here's a new language or a new way we're going to exchange, and it's called FHIR. But then nobody wanted to do it. Why? Because they think that data is their intellectual property. Every healthcare entity will tell you that data, Miriam's health record, is my data. It's not Miriam's data. Blue Cross Blue Shield would say, that's part of my IP. The Hospital Baptist would say, oh no, that health record that happened to be about Miriam Paramore, that's mine. And it was so bad that you couldn't even get your own data. You would ask for your own record. They'll send you a summary of the record if you pay them $25 a page, and then they'll mail it to you. Absolutely ridiculous. So that's a form of information blocking that doesn't have really anything to do with interoperability. But boy, you can't be interoperable if you don't even try, right? So then you see legislation and regulation and things like transparency and coverage, which I've mentioned, maybe I mentioned it before, and the most recent rulings that kind of knock down information blocking. They're saying, no, you can't just hoard things because one hospital is afraid of losing a patient to another hospital, or a health plan just doesn't want to share anything. You are required to give patient access and member access to their data, and it has to be digitally available in a certain format. So now Miriam can have her own data, but it's downloadable in an interoperable framework, right? And so all of those things are necessary planks in an interoperable world, right? And those things are planks in what we build, because for us to help a patient understand like the nuances of how far are you in your deductible? What exact tier does this drug fall on? Have you reached your out-of-pocket maximum? In helping consumers decide the best choice for their buying that drug. that requires getting information, interoperable information. Okay. So foundationally, it's critical. We have the standards in place. We haven't had a ton of enforcement, but enforcement's getting better. And the thing that happened in early April, I think it was April 9th, and Kristen, shout out my friend Kristen Valdez, who's the founder and CEO of Be Well, which is definitely a leader in the personal health record space. Kind of get your own data, you got to put it somewhere, you put it in a Be Well record. That's actually really, really working. So for the first, because the government's made a big push and they had their first wave, everybody's supposed to have a pledge. I will be interoperable. I won't be a data hoarder, so that's really important, all of that to underpin the work that we're doing. And we are injecting data into an interoperable world, or what hopes to be an interoperable world. If you're not interoperable, the data can't flow. Right. And we want that ubiquity. So it's just critical to everything we do. We are, one more note on this, working very hard with the Carin Alliance, CARIN, which is focused on a consumer-facing real-time pharmacy benefit data exchange. Like, why can't I see what the pharmacy sees before I get to the pharmacy? Today, I can't see from my own health plan how much this drug costs, where I am in my deductible, all of that. I cannot see that. And I'm going to tell you, I went on Blue Cross Blue Shield Tennessee's portal, which is my portal, last week to try to look up a drug. Do you know I spent 11 minutes on that website trying to get the answer to, is this drug covered under my formulary? And how much does it cost? Never got the answer, gave up. So, yeah, there's still yet another layer of this, which is you might be interoperable, but completely ineffective at having some sort of UX, UI that anybody can actually use. And that's yet another reason that we have built our conversational assistant, because she'll go out and just get all this stuff for you. But because a consumer doesn't have not a prayer of figuring out this information with today's tooling.
So, as an investor, you're an investor, you're a partner, you're an advisor, and you were just at the WBL Summit. And
yes.
What are you hearing? What's the most exciting opportunity that you're seeing? I know. RxUtility is an exciting opportunity, but like from all these different conferences and different roles that you're already you're already doing and you're already being part of recently. Like, what's the most exciting opportunity?
Thanks for taking this conversation that direction. I'd love to talk about this stuff. So it was probably 10-ish years ago that I started personally investing. And when I say personally investing, I mean acting as an angel investor, because in my roles at various companies, we of course had corp dev, M&A. Many times I led those efforts, product acquisition and so forth. So selling companies. And so I worked with a lot of bankers and a lot of venture capital and private equity firms transactionally for these bigger companies. I had never been an angel investor other than when I ran my own consulting business way, way, way back, which was a HIPAA consulting business, by the way. So I wanted to feel what it was like to be on that side of the table and to get a master's degree in losing money as an angel investor. And, there was the investments were great. I've probably done, I don't know, 6, maybe 7 now. But we brought together a group in Nashville that was not a fund, but was a group of previous operators who wanted angel investing opportunities, seed, pre-seed, and here in Nashville where I live. And we still kind of pretended like we were a fund, so we would diligence things. So we saw a lot of interesting themes come along around clinical decision making. There's been some about clinical trials. And those things are still kind of hot topics from an investment theme perspective. And then as I learned more about really being at the table and what it means to have your money, when you put your own money at work, you pay more attention than if you don't, right? I had not been a limited partner, and I'm very thankful that 4 years ago, three years ago maybe, I was given the opportunity to become a limited partner in Seven Wire Ventures, which is a early stage fund focused on what they call the connected healthcare consumer. That's their overarching thesis. Glenn Tolman, who's a very good friend of mine, who is, one of the four partners running that venture fund, they focus on that thesis. So if it steps at all away from the consumer, the connected consumer, it's probably not within their thesis. But that could take on a lot of different forms. So there's some variety across that portfolio. So it's been really interesting to learn how to be part of a larger group of people partnering around looking for and distributing funds around a theme that I understand and believe in. And then working with private equity, I work as a subject matter expert around with the Goldman Sachs Growth Fund, which is their venture fund, their private equity fund, and then their impact fund based on different. So thematically, what I've seen in the last 5 years is the upward, interest, very high interest in women's health. That's not a surprise to anyone. And at WBL in particular, we have a thing called the WBL Fellows, where we allow, 8 or 9 companies to form a cohort every year to take advantage of the relational capital, the relationship capital that WBL is full of. WBL is Women Business Leaders in Healthcare, which is a network of senior healthcare leaders who happen to be women collaborating together, and we have an annual summit. So in the highlights that the fellows gave, so these are very early companies, seed, pre-seed, who are being mentored by WBL members who are operators, executives, investors, and so forth. We're not an incubator, but it has a little bit of that kind of feel. I think it was 4 of the 8 that were on stage that were doing something in women's health broadly defined. Within that, you have some segments like midlife, you have some that are more focused on pregnancy, you have some that are more focused on breastfeeding. There's kind of a variety of things, but they're all in that big arc. So there's a lot of money chasing women's health, and as a result, everybody with an idea about women's health has got a company, right? So that's definitely a macro theme. The consumer-driven digital health, broadly, digital health is so wide, I think it means almost nothing. And so we have in that sector, though, some things that are pretty significant. They're really kind of been around for a long time around navigation. So I'll give another shout out to my friend Glenn. Glenn Tillman, one of our early partners is a company called Transcarent, which is a benefits navigation company for humans to help just use the benefit they already have. And their customers are large self-insured employers. I think Apple is an example of an employer. So this concept of digitally connecting to the consumer to help them find care, afford care, pay for care, and then manage their own care. So you see a lot of, Zealous is an example, you see a lot of tech that's like trying to make your bills in healthcare as easy as Apple Pay. Healthcare bills are a nightmare. They come like 9 months to 2 years later, and then everybody's forgotten what they're even for. And people are saying, why do I have these bills? So, and I would just say, my last thing I would say is that the revenue cycle theme, broadly defined, and when people say that, you're like, what does that mean? It means everything from sending out a bill, filing a claim to the insurance company, sending a bill to the patient on patient responsibility or member responsibility, subrogation, which is after the fact, somebody thought they got paid wrong and wants a third party to figure it out, and then maybe they're going to have a lawsuit, to the collection of self-pay, which is almost, it's more than half the time it's written off by hospitals because patients really can't pay the self-pay. but there are a lot of companies that focus on getting those last dollars from patients. So those are macros. And then finally, I'd say from life sciences space, the biosimilars, there's kind of a weird peptide craze going on, which kind of drives the Hims and Hers and Roe and Joy and Blokes. So that falls into more kind of consumer health, where consumers are going outside their insurance benefit to get their GLPs, hair loss drugs, lifestyle drugs, some people call them. That's really growing. But the macro of all of these macros is these primary drivers. Healthcare affordability is a crisis at a national level, employer level, and consumer level. At the same time that is true, consumerism is an enormous driver. My sons will never, ever pick up a phone to make an appointment for anything. And if they're not going to sit in a waiting room, right? And then the cash economy, if I can't get what I need, I'm going to do direct primary care. I'm going to pay out of my pocket, like a gym membership to a doctor that'll actually see me without me having a 4-month lead time to try to get an appointment back to access. So affordability, transparency is the other one I'd throw on top of consumerism. People are sick of not understanding what things cost. And those things, along with the ledge-reg side, the big push for PBM reform, which you've seen, and then the price, drug and most favored nation pricing, it just puts pressure, it shines a spotlight. So these are really good things. And those macros then drive the other investment themes that we spoke about, which also drives entrepreneurial behavior.
Amazing. I think that inspires a lot of us to focus on what we are building in the space, and where to start and where to apply pressure to get into the market. So amazing, and thank you for sharing your journey and your thoughts and all the advice that you have given, Miriam. We look forward to seeing you on more stages, advocating for affordable, impactful healthcare for everyone. Thank you for joining the SNS podcast.
Thank you so much for having me. I feel like I'm part of the SNS tribe now that I've gotten to know you and the group. And yeah, let's just keep innovating.
Absolutely. Thank you so much.
Appreciate it.